This is Willie Kemp. This is Anemia, Conditions Causing Decreased Production, Part 1. This is the 6th of 7 lectures on anemia divided out into about 15-minute segments. There are my websites that I have questions on with Dr. Hughes, my Twitter, which most of those haven't been active for a while, but I might start doing that again. And then remember, I'm a forensic pathologist, but I have a very strong interest in general and organ pathology, and a very strong interest in teaching medical students. Before you view the lecture, make sure you've read the disclaimers. If you disagree with any of them, do not view the lectures. Third disclaimer, once again, read it. Make sure you agree with it before you continue. If not, don't watch the lecture. And then if you want to understand my teaching style or have any questions about it, I put together an introductory presentation to kind of explain that. Here are my references again. Like I said, these are excellent books. For a variety of reasons. I have no financial interest in any of them. Just supporting them as something very useful for medical students, them I wish I had when I was in medical school. So these are specific conditions leading to decreased production of red blood cells. Remember, there's 3 mechanisms for anemia, basically. Blood loss, actual loss of the blood itself, red blood cells, and the plasma. And that can be acute or chronic. And then you have increased destruction, which we talked about in the last 3 segments, and then decreased production that we'll talk about in these. And once again, I'll start out the lecture with a question. So read through it, answer it. You don't have to know the answer. It's supposed to come from the material that you're going to view, and it is a tool that allows you to pay more attention to the lecture and get more out of it. And I've been using this ever since I was told that. And we'll go through at the end. So since one of the main reasons for decreased production of red blood cells is iron deficiency, we're just going to talk about iron a little bit. Robbins goes through this from there. So basically, a source of iron, meat, as long as people consume meats, and some people don't include that in their diet, is about has heme, about 20% of that absorbed, and non-heme iron in vegetables, only about 1 or 2% is absorbed. For your functional iron, meaning what the body's using, about 80% is in hemoglobin. The rest is in myoglobin and some other iron-containing enzymes. And then storage iron can be found in hemosiderin, which to me would seem to be inefficient storage because that occurs at, like, for example, in areas of bruising and stuff like that in the skin, and then the iron accumulates there. Ferritin is bound iron that the body is used to working with. And that can be found in a variety of locations. And then for detecting the iron levels, serum ferritin is an excellent one. Transferrin can also be used. And then, if necessary, a bone marrow biopsy. But I think bone marrow biopsy, because of the invasiveness of it and everything, is usually a last resort as opposed to some of the lab testing. So iron in the diet is ferric iron. That gets reduced through ferric reductase to ferrous iron, which is then absorbed. So when that's absorbed, it has to go through ferroportin to get into the blood. If it doesn't, it forms ferritin, and then it's lost with exfoliation of the cells. Hepcidin actually acts to decrease the absorption of iron by acting on ferroportin. And so if it downregulates ferroportin, it's going to make more of the iron go to ferritin in the epithelial cells and then be sloughed with exfoliation of it. So anytime you have an increased amount of hepcidin, that's going to actually block the blockage of it, because hepcidin has a negative effect on ferroportin, so it doesn't allow iron to come in. So iron comes in as the ferrous, it's converted back to ferric. Then transferrin is what carries it. So nice when they have the transport. So when you're looking at the decreased red blood cell production, a lot of them, they actually go back to the MCV. So all 3 of these, iron deficiency anemia, anemia of chronic disease, and sideroblastic anemia, remember, all characteristically have a low MCV, although not absolute. Early iron deficiency can have a normal MCV. And then the other main one is thalassemia. So here, these are the lab tests that would be ordered if you had somebody who had a low MCV and you suspected decreased red blood cell production. So one thing you could do is do reticulocyte count, because if the reticulocyte count is not elevated, that would go along with a decreased production. If the reticulocyte count is elevated, that goes along more with hemolysis, with some form of breakdown. Although remember, thalassemia is a mixture. They not only have increased destruction, but they also have decreased production. So iron deficiency anemia, The iron will be decreased. The total iron binding capacity will be increased. Basically, it's saying, hey, we have the capacity to bind more iron. Please give it to us. Transferrin saturation is decreased. Ferritin, I bold-faced that because that is the preferred lab test for these. That's going to be decreased. And then if you need to, you can use a serum-soluble transferrin receptor, which will be increased in iron deficiency and normal in anemia of chronic disease. So anemia of chronic disease, I've seen anemia of chronic disease and anemia of chronic inflammation, but very similar. So the iron will actually be decreased just like in iron deficiency anemia, but the total iron binding capacity is actually normal or decreased. Opposite of iron deficiency anemia. Transferrin saturation is normal or decreased, and the ferritin is actually normal or increased. So in anemia of chronic disease, they have the iron, they just can't use it effectively. And then sideroblastic, remember the little rings of iron around the nucleus, the iron will be increased, the total iron binding capacity will be normal or decreased because they've basically saturated it. Transferrin saturation is up because it's, like I said, basically saturated. They have plenty of iron, and the ferritin will be increased. So with iron deficiency anemia, the etiology is it's decreased red blood cell production. Remember, I've been trying to do this to kind of go along with the second lecture with the differential diagnosis and kind of breaking the types of anemia up by their mechanism. The etiology of iron deficiency can be chronic blood loss, dietary deficiency, malabsorption, or increased requirements. So it says especially in young patients or pregnancy, obviously when they're making, they can require more iron. Clinical features, it says most are actually asymptomatic. Some have the features that are associated with anemia, weakness, pallor, thinning. They also describe flattening of the males and pica, where they'll actually eat non-food materials such as clay, dirt, things like that would be potentially something they could chew on. Dr. Stern actually lists in his book, it's great, he has like 2 or 3 sentence descriptions of the classic presentation of disease processes, and for iron deficiency, I believe it's young female who is eating dirt or something like that with pica. So the pathology, they're microcytic, the low MCV, hypochromic, so you'll see a larger central pallor, and then you can see some abnormal forms. Remember, one characteristic thing about iron deficiency anemia is they have a higher RDW, red cell distribution width, so a difference in sizes. And one of the things you can see is what's called a pencil cell. So these are all iron deficiency anemia, and you'll notice with the cells is that especially a lot of them have the ring of red at the periphery is smaller, and the central pallor is bigger. So that's the hypochromic. And the bottom, you can see what we always learned was a pencil cell. I've only seen that in a couple references now and everything like that, but that's the kind of the variation in the shape and stuff like that. So, okay, as I said, I put in pictures to kind of time where I'm at, so we're doing okay. We're about halfway through. I don't remember whether this was the Bismarck or the Billings Zoo. If you're ever up in the areas, they're actually both really nice, but just neat little picture for now. So random little point, sorry, but just remember, with iron deficiency anemia, one characteristic feature of it that can help in the differential diagnosis of other anemias, especially of the with a low MCV, is the RDW is increased. So anemia of chronic inflammation or anemia of chronic disease, I've seen it, I learned as anemia of chronic disease. I think I've seen now it's labeled anemia of chronic inflammation. Seems to me the anemia of chronic disease would be better because it's not all just inflammation, but So it's a decreased red cell production. It's associated with just that, chronic disease. So chronic kidney disease, autoimmune diseases, which are obviously chronic. Some chronic infections can do as well, neoplasia. So anything the patient is struggling with for a long period of time. So the chronic inflammation actually suppresses erythropoiesis. And the chronic inflammation can also stimulate hepcidin. And remember, hepcidin is a negative and can also inhibit erythropoietin production. The pathology of the red blood cells, they're microcytic and hyperchromic, which is, not specific for them, but that's just what you would see with that. So, sideroblastic anemia, decreased red blood cell production, same thing as etiology. The description, it's an anemia that's due to the inability to incorporate iron into heme. And what will happen is because you can't incorporate the iron into the heme synthesis will be defective, and you have that iron available. It's not like they're short like an iron deficiency, and that will actually accumulate in the mitochondria, and they'll be in a perinuclear region, hence the name ringed sideroblast. So the diagnosis by this is usually by bone marrow biopsy. There's various forms of it. It can be hereditary or also acquired. Sometimes it just happens, idiopathic. It can be also drug-induced by some. I put one in there because relatively commonly known drug, isoniazid, alcohol, lead, or other ones. So this is a sideroblastic anemia. This is an iron stain. So if you look at the cells with the black arrows and multiple other ones there, you'll see this little stippled blue dots around the nucleus. So that's the iron that's within the mitochondria that is not being effectively incorporated into the heme. So these are kind of the idea of the ring sideroblast. And there's a criteria for actually calling it a ring sideroblast. And I can't remember exactly what it was, how much of the nucleus has to be surrounded or stuff like that. But it's definitely a sideroblastic anemia, and the general idea, is where you have a ring of the blue staining around the nucleus. Okay, so here's the question. So pause, answer it, and then we'll go on to the answer. So a 21-year-old female presents to her obstetrician gynecologist with complaints of being more tired and unable to complete her usual exercise regimen. A review of systems reveals dyspnea with exertion, more so than normal, and also heavier menstrual flows than normal. Testing would most likely reveal which of the following. So of those, it'd be a decreased ferritin and increased total iron binding capacity, because the idea would be that these would be a setup for chronic blood loss, which can lead to iron deficiency anemia. In iron deficiency anemia, you expect to see a decreased ferritin and an increased total iron binding capacity, because it's saying, I have more capacity, please give me more iron so I can bind it, is my way of looking at it. And then here's the explanation I wrote when I wrote the question, if you just want to pause and look at that. And then, as I said, one of the things I learned from Make It Stick, I'm trying to impress upon medical students, is this idea of reflection. So just pause the recording, go back and think, okay, what are 5 important points I learned from this lecture? Once again, I hope there are 5 important points from the lecture, but this is a really good way to cement the material. And then here, I believe this was at the Billings Zoo. This was I think it was a wolf, just kind of looking at us and everything like that. So I hope this lecture has been useful to your understanding of anemia, and thank you.